So today we're going to talk about clinical research in public health emergency. Previously, we had the 1918 influenza pandemic. About 500 people became infected, and at least 50 million people died at that time. Then recently, the SARS pandemic in 2003, and then the H1N1 pandemic in 2009, and then we had the Ebola outbreak in West Africa, 2014, 2016. And we'll come back to the Ebola conflict because some interesting controversies occurred with doing clinical research at that time that has relevance for what's happening in our situation. What kind of research is needed during global health emergencies? Well, we need to improve understanding of the concerns of people affected by the emergency, improve understanding of the concerns of people. So, good. Social behavioral research, make diagnosis quicker, testing, develop new vaccines and treatments for diseases that cannot currently be treated or where treatment options can be significantly improved, that's for sure. Adapt existing ways of caring for people so that the services provided are appropriate and sensitive to their needs, and provide health services in very challenging situations. Okay, so global health emergencies are challenging environments in which to conduct research. They involve disruption of people's lives and great health needs and other urgent needs, not only medical needs, but social economic needs. They are likely to be accompanied by time pressure to act that may be in tension with standard research timelines. There's anxiety and distress on the part of participants, researchers, and the wider community where the research is taking place. Other challenges for researchers include rapid turnover of workers active in the emergency, the inherent dangers of the emergency setting, the tension between doing research and the immediate emergency response, especially in the face of great need. So actually, a lot of researchers are needing to take care of the patients, and they don't have time to be able to do the research. But there is a lot of research going on nonetheless. We need to do the research during these trying times because there are risks of providing inadequate, ineffective, and even harmful care if we don't research these treatments. Someone mentioned about using off-label of drugs. We'll get back to that in a few moments. So actually, if you check clinicaltrials.gov, it just seems like everybody is just picking any off-label drug that has some anti-immune effect and using it in patients. They use it in research as well, but sometimes you wonder what's the rationale of using some of these off-label drugs. So the research provides much needed evidence for clinical management and public health decisions in an infectious disease epidemic. For many emerging infectious diseases, effective diagnostic medications and vaccines are simply not available, and we need to do good research. And where these medical countermeasures are available, the evidence for their use is, quite frankly, limited. So the types of research investigating the virus itself, animal environmental research on the origin of the virus, epidemiologic studies, and there are a lot of epidemiologic studies have reviewed the research that you have reviewed, and I see that you have reviewed a lot of epidemiologic studies, a lot of retrospective studies as well, clinical characterization and management of the infection, prevention and control, including healthcare workers' protection, also including the stresses on the healthcare workers, therapeutic research and development, vaccines, and social sciences in the outbreak response. So a lot of research, but time is of the essence. The point at which an epidemic occurs is the only time to gather the data. We can't wait until the epidemic is over, and we have to generate new knowledge regarding disease characterization, prevention, and treatment. Experience from previous epidemics highlights how time and the research response has been delayed previously, and there's a narrow window of opportunity for enrolling patients during the peak epidemic waves is missed. Actually, when is the best time to test a vaccine? The best time to test a vaccine is when there's a lot of infectious cases. If the pandemic is well controlled, you don't want to go to that place to test your vaccine. You want to go to a place where the disease is rampant. Again, the window for learning in pandemics is often short, and there's a need to balance. However, there's a need to balance scientific rigor against speed. It seems inevitable. Now, let me ask you a question. Should one relax the requirements of rigorous research in order to speed up research? Time is of the essence. Should one relax the requirements of rigorous research? Okay, to be effective, research must be fast, flexible, and integrated with the frontline response. In order to enroll enough patients to get an answer quickly, there is a need for multi-site, multi-country research, and that's been done with the WHO, with the Solidarity trial, and in the UK and Europe with the Recovery trial. So there's a need for multi-country research to enroll participants faster. And however, we have to navigate the requirements of multiple regional and national administrative and regulatory systems. And this slide shows all the different factors that affects research that we have to not consider, but we have to consider not only the ethical aspects, but also regulatory, administrative, economic, research funding costs money, logistic, societal concerns, and political concerns as well. Let me ask you, what kind of ethical issues become more pronounced during the pandemic? This is something that you write down. What kind of ethical issues? Appropriate study design that's sensitive to the difficult context in which research is taking place. Performing flexible review. I like better to use the term flexible review as opposed to fast review. Fast review sometimes gives the notion that maybe you're cutting corners. Enhanced risk to research due to uncertainty of the effect of drugs. Achieving meaningful consent processes to ensure people's interests are respected. Also, equity issues. Someone mentioned justice. Emergencies disproportionately affect people in low-income settings, those who are already marginalized or deprived. Issues about community engagement. Essentially, are we hearing the voices of the community? Are we able to still engage communities when we design research, which involves questions of power and influence? Great effect when we collaborate with investigators in other countries. Is there fairness in these collaborations between the researchers and research institutions in different countries? What about data and biological samples? Are there fair collaborations when we share data? We need to share the data and biological samples in order to achieve faster answers to pressing problems. There are three issues to consider, barriers that could delay research. One regards problems with the regulatory environment, doing research in collaborations, and then we'll spend some time on the innovative research designs. And those are several important barriers to doing research during these times. So we have to have enabling regulatory policy and social political environment. Clinical research operates in a wider policy, regulatory, social, political context. Key features of that context can operate as a barrier or an enabler, and then processes and mechanisms for rapid response are needed. So we have to have, not only do research ethics committee are under time pressures, but there are regulatory on time pressures as well. There has been a lot of pressures on the FDA to fast forward the review process and also issue emergency use directives for medications. And I'm sure you might be following the issues about approving a vaccine sooner rather than later. And then there's issues about partnerships and collaborations, which require strong interdisciplinary and cross-border collaboration. However, there could be multiple challenges to building equitable, fair, and mutually supportive partnership. Getting back to the issue of research design, let me ask you this question. Now, we all know about the randomized controlled trial design. That's supposedly the gold standard. So the question is, when current standard of care is ineffective, someone mentioned previously the use of off-label drugs. Interesting, with off-label drugs, we have the safety profile. Now, for sure, we don't know the safety profile of testing a off-label drug in a new disease that could bring up other safety issues. But when the current standard of care is ineffective, is it ethical to randomize patients to stand to a standard of care control group when testing an already approved drug, approved for another indication? So let me ask you, when current standard of care is ineffective, and it has been ineffective for this pandemic, is it ethical to do randomized controlled trials? During the times of Ebola in 2014, there was a lot of concern about trying to randomize patients to a placebo group. At that time, the thought was that the mortality of the Ebola was as high as 70% in some communities because of the lack of effective treatment. And so when conventional care means a high probability of death, is it ethical to randomize patients to the placebo group? And the assumption was that interventions in the early stages of development was more like the assumption was that off-label drug might be more efficacious than the placebo group. And hence, there was a thought that we had a lack of equipoise, that people thought that an approved drug, an off-label drug, was probably more likely to be efficacious than the high probability of death. And hence, there was some guidance saying that it was unethical to have a placebo group. Also, the other thought was that a lot of communities had a lot of mistrust of the research enterprise, especially when they saw that expatriates were getting drugs not in the context of a clinical trial. And they were saying, why do we have to enter a clinical trial in order to get these drugs? However, the counter argument is that, well, 90% of so-called novel interventions fail to prove to be effective for any indication. And there's the issue of equipoise. Equipoise is when you have genuine uncertainty in the community as to whether which group is going to be more favorable, the experimental drug or the standard of care group. However, we can't confuse the notion of individual equity versus community. Equipoise. So community equipoise is when a significant minority of clinicians are uncertain as to which group is going to be more favorable. And for sure, there might be a lot of individual equipoise, but individual equipoise should not be the more favorable voice in what study design to choose. And in fact, they started a few studies with the Ebola without a control group, and that had a lot of pushback. And the thought is that there is equipoise during the times of pandemic, and that's one of the times in which you should not relax the rigor of research, because it's hard to interpret non-randomized controlled trials. And essentially, the concern with the communities is that you have to communicate reliable information to communities and gain their trust. And you have to gain their trust in the beginning of a pandemic and be transparent with the communities as you try to enroll participants. Now, having said that, there still is the concern. Still about randomizing patients to a placebo group in a one-to-one ratio. So there is this concept of an adaptive clinical trial design. So the question is there a way to minimize the number of participants to a placebo group? And essentially, one type of adaptive design is to test multiple drugs at the same time against a placebo group. An adaptive design is a design for clinical trials that allows for prospectively designed changes. So as you go through the clinical trial, you're getting information about one of the various groups, and you could modify your clinical trial as you get this information instead of waiting until the end. So this is a schematic of such a type of clinical trial where we have several different groups, and you want to add convalescent plasma in the adaptive or factorial design, and so everybody gets convalescent plasma, and in one group you have standard of care, but all the other groups you're testing other drugs. So this slide shows 5 different groups. At least in four of these groups, they're getting something. And even in this group, getting convalescent plasma plus the standard of care, they're getting something. And so the thought is that you're minimizing the number of participants who is receiving standard of care. And this is the recovery trial. Solidarity trial is an example of the use of an adaptive design. It was done in, so the WHO Solidarity trial was was testing 4 different types of drug combinations, and then we have the a European trial that was also testing multiple drugs that you see on this slide. And then another European trial. Again, the greatest strength of a non-adoptive trial or a regular REC does not allow opportunities for modification during the trial. Again, during the trial, you're doing more interim analysis, you're getting more data, and you may drop a treatment group. And you may add another treatment group. Now, having said that, here is a headline that I obtained from yesterday's newspaper in the Wall Street Journal. The reason for this headline, study adds to the remdesivir debate. So essentially, the WHO, who is doing an adaptive design, showed that remdesivir had no effect on clinical outcomes. And the controversy is that, again, what do we believe? The results of an adaptive design or an RCT. Now, several months ago, the NIH did a randomized controlled trial of remdesivir, and they showed that patients taking the remdesivir recovered faster, 10 days versus 15 days. I'm not sure how important that is. Now, there was some effect on mortality, but it was not statistically significant. However, the WH study, the adaptive design, showed it had no effect. So here we have, and some people are concerned that, do we trust the results from an adaptive design? So let me ask this group: have you? I think you might have reviewed the Solidarity trial, a trial adaptive design. I'm not sure. I'm trying to remember, but I'm not sure if this is one of the issues that being problematic for you. That's one of the challenges for RECs, is trying to review studies with these novel designs. So now there are other types of, without belaboring the point, there are other types of novel designs. There's called cluster trials, where you do studies in villages or communities, and the issue is with informed consent, you actually, in some cluster trials, you don't have the opportunity to get informed consent, and then we have the adaptive trials as well. In this article here, Against Pandemic Research Exceptionalism, and what is meant by that? Well, do you allow for what I call less rigorous study research procedures when you're pressed for time, and a concern is that a lot of studies are using small sample size, unvalidated surrogate endpoints, and lack of randomization. And so, on one hand, I think there is a time to use an adaptive design. Even that is controversial, because you want to minimize the number of patients enrolled to the placebo group, but this is not the time to start using small sample size, unvalidated surrogate endpoint, and lack of randomization. So there may be some time for what I would like to call some wiggle room in clinical design, but this is not the point where you would want to make an exception to the study design. Okay. All right. And there's this article that I put on the website, The Carnage of Substandard Research During the COVID-19 Pandemic. This was published just a few weeks ago, and I invite you to look at the article. And I think you all know about how several articles already back in May and June were retracted from JAMA and the New England Journal of Medicine. And so what does that tell you about the review process itself? So let me move along. So the WHO cautions against inappropriate clinical trial. Small, observational, non-randomized study will not give us the answer we need, says the WHO Director General. Okay, using untested drugs without the right evidence could raise false hopes and even do more harm than good and cause a shortage of essential drugs that are needed to treat other diseases. There was a time a few months ago where everybody was rushing out to get these anti-malarial drugs or these immunomodulators, and people with rheumatoid arthritis couldn't get their drugs because and who was stockpiling these drugs? It was physicians writing out prescriptions to themselves, and so they could stockpile the drugs, and so there's a lot of concern with doing these practices. Okay, so getting back to the challenges to the REC, this is the next broad topic I want to address. There's a concern about the capacity of research ethics committee to respond in emergency, where novel research designs are presented for approval in an emergency. This creates additional challenges for the RECs. These designs may not be covered by existing guidance nor familiar to a lot of people on RECs. And then there's this concept of expedited review, and we'll go over that in just a few moments. And then now there was a study, a qualitative research study done with RECs, and the RECs identified that the value of timeliness, responsiveness, and rigorousness as key elements of review, even at times of epidemics that we have to pay close attention to. I want you to tell me, have you changed your strategies to conduct more timely reviews? Here's a list to address timeliness. Most of you have mentioned these ideas, okay? Convene ad hoc meetings, subcommittees, conduct reviews by teleconference or over email, waive deadlines for protocol submission, right? I mean, sometimes when I submit to the IRB, I get the notice this protocol will be reviewed at the next meeting, like in 3 weeks. I said 3 weeks, okay? Rank protocols by urgency, have advisors pre-review the protocols, okay? Willingness to discuss protocols with researchers at the development stage and provide informal feedback. So by the time it gets to your committee or your subcommittee, all the issues have, all the controversial issues have already been discussed. Excessive initiation of research can be delayed and still achieve the study objectives, and ability to respond quickly to protocol modifications. So this whole list constitute successful strategies in order to enhance timeliness of protocol review. So you are employing all these strategies. Also, responsiveness. You offer training for REC members regarding review of disaster research protocols. I mean, you know what type of research is coming down the line. You already looked at, inadequate surrogate markers, sample size, establish policies and procedures, change your SOPs. You mentioned use of knowledgeable advisors, develop partnerships between RECs. What about this concept of central review? In order to increase the sample size, we're talking about not only multi-country, but have you reviewed protocols that involves different emirates in your country? And would you allow, is there, there is this concept of central review, but is that something that to consider? Is that something that's being done? Do two IRBs have to, trust me, there's a lot of issues to be worked out with central review between different IRBs, but I'm just thinking, unfortunately, this pandemic is going to be with us for a while. So I'm just wondering if that's something to consider within your country. In order to enhance the sample size, should there be cooperation between the different emirates and increase the sample size? Something to think about. Rigorous, resist the pressure of urgency, provide careful scrutiny of all protocols, especially the high-risk one, and resist external pressures and maintain the independence of REC review. So the issue is you want to do these reviews quickly, but not at the disadvantage of careful scrutiny of all protocols. And there is the concept of proportionate review. If the protocol is low risk, and also if the proposal is going to give meaningful results, then you don't have to spend that much time on those protocols. And you may want to enlarge the category of protocols that you do expedite review. Okay. All right. So another question. Which of the below represent major challenges to informed consent? We're going to switch gears. We talked about study design. We're going to say a few words about informed consent. So which one present even more challenges to informed consent than usual? So, and this slide just summarizes the options in the previous slide. Again, with the concept of medical vulnerability, potential participants may think that this is their only option for treatment, okay? Difficulties of explaining complex study design, and then a theoretical question, is informed consent even possible given how little we know about COVID-19? And how do we explain the risks? We just have to say that, right, there may be unknown risks that we don't even know about. And that makes it even more complex to get informed consent. So I'm not sure, may be interesting to see, actually that would be a good study to do, to look at the informed consent forms that you guys are reviewing, and seeing whether these consent forms are successfully conveying the complexity, the uncertainty, whether we need to, I don't know what kind of changes are needed in the informed consent. So that may be a good study to do, to look at the informed consent form and see what kind of changes we should be suggesting. Now, another subject that I brought up previously, should there be a tolerance for riskier research? And I take this notion from this article, Pandemic Ethics, the case for risky research. But before we go into that article, is it ethical to allow riskier research during a pandemic? That article talks about this concept of risk parity. You know, we're asking our healthcare workers to take on more risk during this time. So is it only fair to also make an allowance for participants to take on more risk when they go into research? And you ask an excellent question. What do we mean by more risk? So, as someone mentioned before about lack of safety data when you review trials. So, what about skipping animal trials? You know, getting safety data from animal studies for promising treatments. Do we not demand robust safety data in order to speed up studies? That's one way to think of the notion of something that's riskier, lack of safety data. Is it, now, I asked the question in the beginning of this presentation, is it ethical to allow changes in rigorous research in order to speed up studies? And this may be one way to do research faster. That's a little riskier. And in normal times, the answer would be no. But this concept of risk parity, we are, healthcare workers are taking on more risk. So should that occur in the research setting as well? Now, having said that, an important value associated with this is transparency. We cannot lose trust in the research endeavor. And so we have to be transparent when we do this. And next week, we'll talk about human challenge trials, okay? And what I mean by that is that human challenge trials is when you take healthy volunteers and you deliberately infect them with a weakened coronavirus in order to assess vaccines. And the concept is that that you could come up with a vaccine much quicker. We'll see. Well, you know, we have all these vaccines being tested in the regular field trials. And some people will say, well, we're going to get an answer, okay? However, I don't want to be cynical here, but the concern is that a lot of those vaccines are not going to be as effective as we want them to be. And human challenge studies, I'll just say a little bit about them now, is that human challenge studies, by having a human challenge studies, you'll know which vaccine will be possibly more effective before you test them in field trials. So there is this concept about should we relax our guidelines or our tolerance for risk. Hopefully, I brought up some issues that we need some more time to reflect on as we go through this difficult times. Any remaining thoughts?